Hello dear viewers, in this video I am going to discuss how do I do the initial hemodynamic management for patients presented in sepsis septic shock to my ICU. Though my approach is based on surviving sepsis guidelines, there are several nuances involved for how I take these guidelines from bench to bedside. I am Dr. Sunil Garg from Essentials of Acute Care. Before we initiate, have a look on this question to solve it and solve it again after watching this video. Regarding management of sepsis and septic shock, which of the following statements are most appropriate? Option A, maximum dose of norepinephrine is undefined as goal is to achieve mean arterial pressure. Option B, hydrocortisone is suggested for all patients of septic shock. Option C, ringer lactate should not be given if patient presents with hyperkalemia. Option D, patient do not respond to 30 ml per kg crystalloids. All patients must be administered albumin. Option E, guidelines suggest lactate guided resuscitation over not measuring lactate value. Let us understand first what is hemodynamic management. Hemodynamic management in sepsis septic shock refers to a set of interventions done to attain the goal of mean arterial pressure and optimize cardiac output so the arterial oxygen delivery can be increased and signs of impaired perfusion and oxygenation improved. And the goal is to achieve mean arterial pressure of 65 mm of mercury since it determines perfusion pressure, optimize cardiac output, hence oxygen delivery, and follow and reduce the lactate value and improve capillary refill time, which in turn ensures effectiveness of resuscitation. What we do to achieve these goals? We administer at least 30 ml per kg of crystalloids over first 3 hours to all patients who present with sepsis-induced hypoperfusion or septic shock, except patients with sepsis without shock with poor LV ejection fraction, means ejection fraction less than 30 to 35%, where we individualize our approach based on ongoing monitoring and observations, which we will discuss later in this video. In general, we prefer ringer lactate or plasma light over normal saline, particularly if patient has acidosis irrespective of plasma lactate or potassium value. What we do if patient continue to remain hypoperfused at the end of initial resuscitation with 30 ml per kg over first 3 hours. We administer more boluses to such patients. We prefer more boluses of balanced crystalloid in such situation if the source of sepsis is primarily intra-abdominal and or patient is in ileus or sepsis is associated with diabetic ketoacidosis. We prefer albumin if we want to restrict the volume intake, particularly in patients with primarily lung infection or associated lung injury in sepsis. If patient's response to fluid administration appears to be suboptimal after administering 10 ml per kg as initial bolus and patient continued to remain hypotensive, we administer norepinephrine as a vasopressor of choice as per guideline early during the management of septic shock. We initiate norepinephrine at 10 to 15 microgram per minute or 0.1 microgram per kg per minute. Regarding administration of vasopressin in the management of septic shock, we administer vasopressin as a non-titrable infusion of 0.03 unit per minute as per guideline when the goal of mean arterial pressure of 65 mm of mercury is not achieved after initial fluid resuscitation with 30 ml per kg and the dose of norepinephrine of 0.4 microgram per kg per minute or more. What if patient remains hypoperfused even after attaining mean arterial pressure of 65 and adequate volume replacement? We prefer administration of dobutamine in such patients at 5 to 10 microgram per kg per minute if patient has global hypokinesia of left ventricle due to sepsis. What if patient left ventricular ejection fraction is normal and patient remains hypoperfused even after attaining mean arterial pressure of 65 and adequate volume replacement? We prefer to increase the goal of mean arterial pressure up to 70 mm of mercury by increasing the dose of vasopressors if patient has history of chronic hypertension. If patient continue to require vasopressor therapy despite adequate volume replacement and norepinephrine dose of 0.4 microgram per kg per minute or more for few hours, we administer hydrocortisone to such patients in septic shock. We initially give 100 mg of IV hydrocortisone as a bolus, followed by continuous infusion at the rate of 8 mg per hour. The administration of hydrocortisone usually coincides with the administration of vasopressin in such patients. While managing patients, we continue to monitor and observe various parameters to assess the effectiveness of measures taken and if any further therapy or escalation or de-escalation of therapy is required. These parameters include heart rate, mean arterial pressure, capillary refill time, and hourly urine output. We monitor lactate. We look for the IVC collapsibility initially and at the end of initial fluid resuscitation. We monitor arterial pressure wave tracing to look for the respiratory variation, monitor plateau and peak pressure. We do echocardiography to look for the chamber size. We do lung ultrasonography to understand the presence of fluid overload. We occasionally use PLR testing to assess the fluid responsiveness. Essentially, we do not rely on single parameters to do hemodynamic management. Rather, we make informed decisions based on combination of parameters. What we do not do, we do not use hydroxyethyl starch or gelatin as intravenous fluid, terlipressin as vasopressor, levosimendan as inotropes. We do not use albumin in patients with traumatic brain injury, and we rarely use epinephrine as we believe it causes more tachyarrhythmias and increases lactate value, which interferes in our assessment of adequacy of resuscitation. We do not do invasive cardiac output monitoring routinely in all our patients. Regarding vascular access, while managing patients with sepsis, septic shock, we prefer invasive arterial pressure monitoring than the measurement of non-invasive blood pressure. We prefer radial arterial vascular catheter over other sites of arterial catheter. But when the patient has severe peripheral vasoconstriction, as evident by skin mottling, peripheral cyanosis, and cold extremities, or if patient has history of atherosclerotic disease, we prefer femoral arterial catheter insertion over radial arterial insertion. We do not wait to establish central venous access before initiating administration of vasopressor, as it delays the administration of vasopressor. We start norepinephrine with wide bore peripheral cannula in upper limb, awaiting central venous catheter placement. Here I finish. Thanks for watching this video. I would appreciate your feedback, suggestions or comments. See you again in my next video on some very interesting topic. Till then, bye and take care.